Good morning and welcome to the Substance Abuse Awareness Month lecture series number 1, and it is on alcohol withdrawal management. And my name is Gail Springer, and I am the mental health clinical nurse specialist, also a psychiatric ARNP, and have a specialty focus in working in substance abuse. And so today we have our talk on alcohol withdrawal management. And so first thing I want to do is go over our learning objectives. There we go. Okay, so we're going to talk about who's at risk for alcohol withdrawal syndrome. We'll identify the alcohol withdrawal symptoms using the CEWA scoring. We'll talk about withdrawal. And then we're going to go over the general medical therapy for alcohol withdrawal, and then we'll talk about coordinating ongoing chemical dependency treatment. We do have people in the room, so I really like to be able to ask questions and talk with people. So the first question is, have you guys managed anybody with alcohol withdrawal?
Yes.
In the last week?
No.
Oh, really? I'm surprised. So first thing is we want to think about alcohol use and how many people fall into the alcohol use category. So we're really looking at millions of people. And we have a higher percentage in the critical care areas because they have lots of medical complications. So you see a lot of them. And then why do some people become addicted? It's really not as simple as we used to think it was, but it's really that, and I like this slide, and it came from one of the national talks, is we're looking at the biological piece and the genes that people have, but we're also looking at the environmental piece. And I just put the slide in to help us have some empathy towards people, that the addiction around alcohol use really is a brain disease. And this brain disease causes things like the compulsion to seek substances. It's loss of control around limiting their intake is very hard. And then it's also the emergence of a negative emotional state when access is limited or prevented. And I really like this slide here because it helps us really visualize into people start drinking because of the positive reinforcement. I mean, all of us, who've drank, I mean, most of us have, we've felt the little buzz or the feeling that you have. Well, for people who have addiction, that's how they get started, is it feels good, They're not doing something that feels bad. And then over time, you get the negative reinforcement, is they feel so miserable they have to drink to stop that feeling. So when I put it in this kind of perspective, it helps me really bring up the empathy and the understanding for it really is a disease. Especially if you guys get them again and again. But I do want to say to my critical care nurses friends is that you guys saved their life. And in saving their life, you get them to me so I can get them into treatment. So I just want to value and appreciate all the things our critical care nurses do. You really do. You save their life. And then I see them out on the floor, and they're very grateful. And I don't know if that comes back to the critical care nurses on how grateful they are that you have saved their life. So I'm just here to say that too, and say thank you for all you guys do, because I really think it's super amazing that you guys are here. So who's at risk? We went through that. I'm going to skip ahead. Really, 20% of our 20% of our medical inpatients have some kind of unhealthy drinking. In the critical area, it can be up to 40%. Oh, wow. And 75% of these are alcohol dependent. And then I think for the critical care unit, I just want to sort of think about when we think about understanding alcohol, and we really have to do a thorough intake. And there's this great study out of St. Joseph's Hospital, one of our hospitals, that they looked at poor outcomes. And what they found basically is poor outcomes related to us not screening these patients in and not finding out about their alcohol use until about 24 hours into their stay. So it's, you know, a combination of nursing and physicians and the LIPs. I guess one of the take-home messages, we want to make sure we're thinking about alcohol use when we get these patients in. So when they're there, do you usually pretty much know that they have an alcohol drinking history? And if you don't, what can you do to find out?
Usually it's family that will oust their family members.
Okay.
Oftentimes the patient themselves don't disclose or consider it actual alcohol intake.
Right, they'll make it a lot smaller than what it actually is. So usually, yeah, I mean, that's usually my key is I'll ask family. If they start going, well, I have maybe a couple drinks a day, nothing much, you know. And, I mean, not to stereotype, but I'll look at their overall appearance too, for the most part. But yeah, family I think is the biggest key.
Yeah, and I think that's exactly what I was hoping to hear, is that you start your nursing detective work, and you start sort of asking questions and figuring out what's going on here. We can also go through the chart, and sometimes past admissions, looking at chart review, you can look at past admissions and find out, there's some drinking here going on. So I think that's helpful. And then these are just some of the poor outcomes. If we don't catch it early, we get sitters, we get restraints, we get long lengths of stay. So just reinforce that part of catching it early. And then alcohol withdrawal versus disease. So, I mean, there's a lot of diseases that mimic alcohol withdrawal symptoms. Like, you know, sepsis, stroke, hemorrhages, traumatic brain injuries. Certainly metabolic alterations and things like that. So alcohol screening, this is the screening tool that you guys use. Do you recognize it? I'll let you guys be the first to know that we got approved to get a new screening tool that is going to be coming with the EPIC upgrades. We're thinking after April of 2019. Nothing happens quickly, but it's coming. And the screening tool will actually have us asking, do you drink 4 or more drinks in the day? And that's sort of really the cutoff for risky drinking or problem drinking. And the other part that I'll just say today that'll come on the screening tool is they'll ask about using prescription drugs for in a non-prescribed way. And that is sort of the other thing that we'll capture with our screening tool. And it's an evidence-based tool that's coming. So screening, we got to ask how much, when, frequency, last drink, withdrawal history. That will tell you if they had DTs before, they're likely to have it again. History of seizures, blackouts. Check the blood alcohol level. I guess I always look at liver enzymes. If they're elevated, and I think maybe alcoholism. And then the other thing that we have now is there's the PAUSE scoring. Have you guys seen this yet? It's built into the Med-Surg alcohol withdrawal order set. And some of the critical care areas have started using the Med-Surg one, because the Med-Surg one got massively updated about, I would say, 6 months ago.
PAUSE, pause?
Yeah. So it's built into it, and it's built into the alcohol withdrawal order set in the Med-Surg. And the PAUSE is the prediction of alcohol withdrawal severity scale. So interesting things that you ask about: use in the last 30 days. You ask about blackouts. You ask about withdrawal. You ask about history of DTs, or have they ever been involved in treatment before? And this, if you have 4 or more, then it's predictive of more high-risk withdrawal, and we should be more aggressive with giving our medications.
And that's daily? Is that daily or just average,
The pause,
the 4 or more drinks daily?
yes,
They have to be a
daily.
daily drinker?
Yeah. Okay, and this is the new DSM-5 diagnosis. So this is how we diagnose alcohol withdrawal now. Now it's an alcohol use disorder, and then we rate it as mild, moderate, and severe. And the reason I put this in, because it really shows you why we ask the questions we ask. Because here we have now withdrawal history, tolerance. We have desire, attempts to cut down. And here we just count numbers. And then if they have 2, they're mild, and then more, they're more severe. So here is the ICU alcohol withdrawal order set. And I pulled this because it directs us into how you guys are managing withdrawal. You use lorazepam, and then if lorazepam is not working, you're using phenobarbital. Is that true for you guys? Has that been your experience?
We're using a lot of Precedex.
Or you use a lot of Precedex now?
You're right.
Yeah.
The problem we have with the Precedex though is that some of the nurses aren't also giving the lorazepam. So when we're trying to take them off of the Precedex, it makes it difficult to transition them off the Precedex because they're not getting the lorazepam to transition.
So it's been helpful to get both at the same time. So,
Especially if you're trying to transition off.
mhm. How long are they on the Precedex?
It's very dependent on the patient and how well we can manage them. It's always ideal, we always try to do sedation vacations to wean them, and based on individual patient tolerance and safety.
Now, are these guys intubated? No.
Not necessarily. Some of them are, but not necessarily. You don't have to be with Precedex.
Okay.
Yeah.
Okay, a withdrawal order set, again, stressing the thiamine. There's mixed research about thiamine, but the standard thought process is you need to give thiamine first, thinking our alcohol withdrawal patients are vitamin deficiency, and vitamin B1 works with the enzymes that if you give glucose first, before the thiamine, then it breaks down and it causes like the swelling, so that's what gives you the encephalopathy. So we try to give the thiamine first before we give any kind of dextrose. Is that your understanding, pretty much common practice there?
Yeah, I don't think we're giving a whole lot of dextrose.
I was gonna say, I don't remember that.
And then you don't, do they eat or? See, the problem is for the med-surg units, they feed them. So then they get the dextrose that way, the sugars that way.
Usually if they're at a point in ICU, they're not usually eating. They're usually coming back because they need such high doses of lorazepam and or we're having to transition to the Precedex drip that they're worried about a potential loss.
And you only do the Precedex drip in critical care. Yeah. So still, this is just the base set. So we got the IV once now. You give 100 milligrams, so that gives the loading dose. And then this is the actual breakdown of the protocol for those who are not intubated. And the reassessment, you use both the CEWA and the RAS scoring. And how often are you doing those scoring?
Based on patient need.
Okay, so the higher the score, the more frequent we're
Right.
doing it,
Right.
kind of concept. Okay, and then we can also go to phenobarbital. And typically we switch to that when the lorazepam is not working. And then when to notify the provider is when, you know, what I guess the take-home message would be to make sure you notify the provider early. And sometimes we let our patients are in withdrawal and the management process is not working and we need to go to something else. So that's helpful. Okay? And then just, again, when to notify the provider. And then our CEWA scoring. Any questions on the CEWA scoring and how that's, you guys pretty confident? I think you guys are pretty good at that. Just remembering we have to do it more frequently if their scores are higher. And we can even, you know.
I find going out to the units that they're oftentimes underscored. Nurses are afraid to score them where they're actually at times, and trying to get them to give a good score so that they can give a reasonable dose that the patient needs to get on top of things is crucial.
Yeah, and you know, there's lots of evidence around CEWA. I mean, it's sort of the gold standard of practice. And it's supposed to have inter-rater reliability, so what you score is what I score. But I think that you have a good point, is that it is true that some nurses are somewhat reluctant to score it as high as they need. I think in your area, you're certainly much more comfortable giving the higher doses than the med-surg nurses. The higher doses that they need,
Right.
you know. So here's CEWA, just skip through that, how we doing on time? Okay, I've got about 7 more minutes. Okay, labs, go through our labs. We want to certainly look for the urine tox screen, and we want to make sure we have that. I always like the blood alcohol level, but we don't always get that. Sometimes they order it, sometimes they do. We look at liver function tests, and we sort of think 2.5 times normal is indicating some kind of problem. That's our cutoff for when we use lorazepam. So if the liver function tests are 2.5 times higher than normal, then we have to go to lorazepam. But otherwise, I really prefer Librium because it's longer acting. Whereas lorazepam, you're always sort of chasing it. You know, they get it, they're sedated, but you have to really stay on top of it, which I suspect you guys do very well. But on the floors, it's more of a hardship to stay on top of it, you know, that frequently checking back. So there's a lot of fluctuation with the Ativan as well, and as opposed to the Librium where they have sort of a more stable state. Okay, benzodiazepines, first line of defense for alcohol withdrawal. Like this is the med-surg piece. They're actually going to symptom-triggered dosing. So there's the difference between symptom-triggered and fixed. And pretty much you guys use symptom-triggered as well. Based on the CEWA score, we give more of a dose versus we give a scheduled dose, which is the fixed dosing. And the research will show you that symptom-triggered is probably the better way that you're doing it. Okay, let's go through these. Go through vitamins. Okay, these are just the adjunctive medications. Don't know how much you guys are using these, but there's the gabapentin, and that does help with decreasing the withdrawal symptoms. We typically use a dose of about 300 milligrams 4 times a day. There's the beta blockers that you can use. There's also the alpha agonists like clonidine. We use a little bit of clonidine that helps with the withdrawal symptoms. We use the propofol, and then Haldol. Do you guys use much Haldol?
A little bit.
When they start into the delirium? Yeah, it's a standard medication. So we want to make sure we use, depending on the degree of agitation. Knowing that alcohol withdrawal is really a brain disease, and their brain is swelling, you know. That's where the delirium comes from. So there's the dexmedetomidine, which is similar to the clonidine, I think the critical care uses. And then the phenobarbital. And then these are medications. So just kind of do a few minutes on what to do after you guys have taken care of them, you've gotten them through withdrawal, and to not stop there. That there's ways to start to connect them with treatment and ways to help them along with the process. But there's certainly medications out there that Antabuse, the Camprol, and the Vivitrol, the naltrexone, that help with management of ongoing abstinence. And we want to offer them some hope that there are medications out there that do help with that, to decrease the alcohol craving. Okay. And then, let's see, this was just general medical therapy. Sit through complications. So the Wernicke's encephalopathy is the one that we're trying to prevent, and so that's giving the thiamine early. Korsakoff syndrome, the confusion that happens. And then, so here's when they start to wake up, what do you do with them? And I just wanted to put in some slides on change talk and how to talk to them around eliciting change and being open to the possibility of ongoing treatment. And that often them being here in the hospital is a catalyst for change. And if we can support that process, then we have really helped them out. So just things are, are there any changes you want to make? How might you go about this in order to succeed? So you can see these are asking open-ended questions that use sort of a motivational interviewing technique of having them answer it so they answer it for themselves. What would work for them? You're the expert on you. What would help you get ready for treatment? So we can do what we call pre-treatment, getting them ready to think about treatment. And so it's just, what ideas do you have for making changes? And then we can help them with the process. Is there anything that you think you should or ought to or need to change? Just asking them about that. And I think I think nurses are really good about being non-judgmental and being supportive and understanding. Nursing really is a profession. The patients are shaming themselves so much that they're beating themselves up. That we're just here to offer them a different pathway. And then always add the withdrawal care plan. There's a withdrawal care plan in Epic, and you can just select it and just remind you to add the care plan in. It's just one of the templates now that they have in Epic. And it's what you guys are doing. Supportive, manage withdrawal symptoms, manage fluid electrolyte balance. So I always like to see that on there when we know. So the care plan. And so really the care plan is, of course, our stabilization and then management of our doing a CD consult or psych consult. But we do have a CD consult service, setting up with follow-up appointments, working on some kind of relapse prevention plan. And these are the ways that we can connect with people. I had a critical care nurse a while ago call me and have somebody who was interested in treatment, so we got the drug and alcohol counselor to come in, and so there's the DAX program, drug and alcohol counseling service for the people who have insurance, because then they can slip right into Lakeside Milo. And for those who don't, then there is Catholic Community Services and Evergreen Recovery Centers has a counselor, CDP, chemical dependency counselor, come in, do the assessment, and then they can help us coordinate into treatment. Just so you know, we have actually gotten some people directly from the hospital into chemical dependency treatment. directly from here.
Do you find that when we do have people interested, we're able to find then the resources that they need?
Yes, we can certainly get them started on the process and connected to it. And then that's the references. Any questions?
Thank you
Right
so
on time, 30 minutes.